It's really wonderful to be here today, and I'm going to be talking about something that I'm absolutely passionate about, and that's helping GPs prescribe low-carb diets. And I'm going to start with a confession. I was a few hundred hours into learning about low-carb medicine when I realised I had two big problems. How is it going to explain this to patients in a small amount of time, and how is it going to teach it to other doctors? Because being a GP is a really difficult job. You are seeing patients in 10 to 15 minutes, and they can come in with any disease involving any body part from any age range, from babies through to the elderly. There's a lot of mental health, lots of red tape, and patients come in with shopping lists of agenda, meaning that they want more than one thing dealt with in that consultation, and it's usually not nutrition. And please excuse the box, but it's hard to make ends meet in general practice, and a lot of surgeries are closing down. So today I'm going to be talking about the GP landscape, things that doctors could say if they've got a small amount of time, what they could do if they've got a longer period of time, how to navigate the guidelines, and what pitfalls you might face. And I do have a few disclosures. I'm the founder of Low Carb Scripts, which is an online training platform designed to help health professionals upskill as quickly as possible in low-carb medicine by providing really concise, curated courses that are clinically relevant, lots of case studies so you can interpret pathology, and also providing the tools and the strategies that you need to implement this in a small amount of time. And it's open to any health professionals, including allied health. I'm also a mainstream GP. I work at a practice with 27 doctors, including 5 GP registrars that I help supervise under the College of GPs. I take medical students from the University of Queensland, and I'm a scientific committee member with the Australasian Metabolic Health Society. So being a GP is like this. At the beginning, your patients are like these healthy yachts. These are the babies and the young people. And then by the end of their life, or sometimes even in the middle of their life, they start to look like these rusty hulks, and you're desperately trying to keep them afloat with Band-Aid medicine that just doesn't work very well for chronic disease. Yet GPs have the power to alter health trajectory, but you need to have the right target and you need to have the right intervention. And like most of you here today, I strongly believe that the right target is metabolic dysfunction and the right intervention is low-carb nutrition. There's also so many opportunities in general practice because we are the people who see metabolic dysfunction first. So you can recognise it, flag it, intervene early. And if you help one person in the family improve, often the whole family improves. We also see the patients loads of times, so there's many opportunities that we can act with patients. There are certainly some golden opportunities if someone's newly diagnosed with diabetes or pre-diabetes, any component of metabolic syndrome or fatty liver, any related conditions like polycystic ovarian syndrome, if you're about to escalate drug therapy, or they're coming in for their driver's medical. And we have to remember that GPs have got broad knowledge and skills. They just don't know yet that insulin resistance underlies most chronic disease. They haven't been taught it. And there are 30,000 GPs across Australia. So if you can help just a few of them improve their prescribing of nutrition, you can help a lot of people. And what GPs are great at is we plant seeds, which means although that idea may not take sprout initially, maybe not for months or years later, eventually it might. And I would argue that every person sitting here today at some stage had a seed planted that led to self-experimentation and then onto your journey here today. GPs are also experts at chunking, and this means they take a larger intervention and they break it up into bite-sized pieces that they deal with one at a time. So in other words, you're taking one piece of the puzzle at a time, but you see the patient over a long period of time because this is cradle to grave medicine. And you're also aiming for progress, not perfection. So most people in Australia will be following a standard Australian diet with upwards of 250 grams of carbs per day. So any downward trend of that is very helpful. So they may meet a Mediterranean approach with 130 grams of carbs or a paleo approach with 80 grams of carbs. They don't necessarily have to reach a ketogenic diet at under 50 grams of carbs per day. And in fact, I rarely prescribe a carb target for patients. So what's some helpful advice that we could give in between 1 and 3 minutes that's going to be better than prescribing the food pyramid? And I would suggest that you just use 1 or 2 of these and then invite the patient to come back for a longer appointment. Or you could use it to chunk an intervention. One of the best things you can do is to take a dietary history, to simply find out what the patient is eating and drinking in a day and what time they're eating, because this tells you so much about your patient. It tells you whether they're a single parent or a fly-in, fly-out worker. It tells you what food they like to actually eat, and it also enables you to suggest a simple swap, like low-carb bread, for instance. Now, it's much easier to explain insulin resistance using the overflow paradigm of Jason Fung than it is to actually explain insulin resistance. And so what this means is that I'd simply say to patients that sugars come into the body in the form of fruit, sugar, and starch, all breaks down into sugar. And once your bowl is full, it starts to overflow. And the blood sugar may start to rise, or it gets turned into fat around the middle, fat in the blood, fatty liver. And so you need to stop the sugars coming in. Something I say a lot to patients is your blood test shows that you're carbohydrate intolerant, and I would recommend that you reduce your carbs. And the good thing about this is that most patients know what carbs are because we've been telling them to eat them for decades. So you can explain that their blood is getting more sugary when you're explaining the HbA1c, which is what David Unwin does. And you could also explain, as Dr. Ken Sakaris has, that sugar is sticky and it sticks onto the protein in the blood called the HbA1c, and we can measure this to see how sugary your blood has been in the last 3 months. And then it's important to tell them where they are, that they have got diabetes or pre-diabetes. And diabetes is diagnosed with a HbA1c of 6.5, and diabetes is 46% reversible with a low-carbohydrate diet, and pre-diabetes is 93% reversible with a low-carbohydrate diet, and that's using David Unwin's 6-year figures, and his 8-year figures are even better. And you may notice that I start pre-diabetes at 5.6 on this graphic, and that's because the atherosclerosis risk and community study shows that your risk of heart attack, stroke, and death go up astronomically from 5.5. So I don't see the point in waiting till they reach the Australian definition of 6% or the US definition of 5.7%. If you're in the game of prevention, you want to target them when their risk is going up. And patients may say, but I don't eat sugar. And as Dr. David Unwin says, well, what do you think's making your blood sugary then? And this is a great chance to explain how starch breaks down to sugar, that it's simply chains of sugar joined together that breaks down into single molecules of glucose that get used by the body for energy. And Paul Mason has done a similar graphic to this before. You could explain that fruit is sugary, to have a maximum of 1 piece of fruit per day, and not bananas and not grapes. It contains a type of sugar called fructose. You could explain, as Dr. Sarah Hellberg had said, no GPS, no grains, no potatoes, no sugar, and potato includes sweet potato. You could recommend that they have eggs for breakfast but no toast, or if they're not hungry, perhaps they could skip breakfast. You could recommend that they eat more protein, that their body is made of protein, and to have a good palm size each meal, and that a serve of eggs is 3 eggs. Recommend that they eat less things out of packets, and this reduces their intake of processed food. And Dr. David Unwin just recommends that his patients have meat and veg, leave the starch off the plate, replace what's white with something green. Now, there are some cultures that do have starch as part of the meal traditionally, such as Asian or South Asian communities might have rice or a type of bread, and you could recommend that they eat the carb last. And by doing this, they reduce the insulin and glucose rises, plus they may be more full from eating the protein and the veg and not eat as much. And in this 2019 study by Shukla, you can see that he gave patients the same meal, protein, veg, and carb, but they just ate it in a different order. And those that ate the carb first, which is represented by the yellow line, had a much bigger increase in glucose levels, followed by a big reactive hypo, than those who ate the protein or the veg first. Now, there are two strategies to lower insulin. Eat less carbs or eat less often, or you can do a bit of both. And in the past, people used to be slim. They used to eat 3 times a day and they didn't snack. And Dr. Jason Fung has done similar graphics to this. And then the food pyramid came in and we told people to eat 6 times a day, eat high carb. So the first step of fasting is to just eat 3 times a day, don't snack. I think it's very important to teach a patient how to read a food label to help navigate the high-carb world we live in. And they only need to know a few things. It's very helpful if you've got a food label to show them and to give them. But basically, they want to read the ingredient list first, and they want to pick something that's got less than 5 ingredients. They want to understand everything that's on that list. Then they want to look at the carbohydrate total per 100 gram. And the figure that's circled here is 12.4, and that's too high. You want them to aim for 5 gram per 100 grams or less. And you want them to avoid sugars and vegetable oils. So the basic advice is pretty simple. It's eat less carbs, eat real food, eat more protein, eat less often. And if you really do that, add a bit of salt. And you can see that that takes less than a minute to say. So there's a lot of value in what we call signposting, which is simply referring the patient to a helpful source. And in this 2022 feasibility study in the UK, they got GPs to simply ask, would you be interested in learning about ways to improve your diabetes or pre-diabetes? And if they said yes, they were referred to an app or a website. And of the 350 patients, about half of them took up this offer. About 30% of those actually went and registered, and about 30% of those actually completed the program. But those that completed it lost 7.2 kilos versus like 1.6 kilos. And their HbA1c reduced by 3% versus 2%. And they also reduced medications. So that's a very powerful intervention for 1 to 4 minutes work. So what are some helpful sources you could refer patients to? Well, you could refer them to the Low Carb Down Under website to find a doctor or a dietitian or other clinician who can do low-carb medicine or is interested in it. You could refer them to the Diet Doctor website in the US, or in Australia, the Defeat Diabetes website or app. You could recommend that they look at the Freshwell app, which is a free UK app which has got lots of information in a very simple way about carbohydrates and carbohydrate swaps. You could just recommend they read a helpful book. So I've got Peter Bruckner's Diabetes Plan in my room, and I just put it on the desk and they take a photo of it. So it's very quick. Now, if you've got a longer amount of time with the patient, and this by far is my much preferred method, because you don't have the attrition rate that happens if you refer them to another source, and I think it's a lot more effective. The patient needs to know where they are health-wise, that their blood is getting more sugary or their liver's getting more fatty. And then you need to explain why low carb is recommended. And to do this, you need to explain physiology simply, because it's different from any other diet they've ever been prescribed by anyone. And I use a little 10-minute PowerPoint to do this with patients, followed by a handout, but there's lots of different ways you could do this. But basically my spiel is that fruit, sugar and starch break down to sugar, and that makes their insulin levels rise, and that makes them store fat. And there's 2 ways to lower insulin. You can eat less carbs or you can eat less often. And if you do this, you need to add a bit of salt, because when your insulin goes down, you pee out a lot more salt. The patient then needs to know what to eat. If you've told them to stop their wheat bix, their sandwich and their pasta, what's left? And they need to know when to eat, which is when they're actually hungry and less often than before. I do teach them how to read a label, and your job as the clinician is to find out who is your patient, what are their food preferences, what pressures are on that family, what culture do they come from. In terms of the provision of information, in general practice, you definitely need very time-efficient ways of doing this. So you need to have your spiels, your handouts, your digital images ready to go. And you need to remember that health literacy is very low, usually that of a 5th grade level. So even if someone is an executive, their understanding of health is a lot lower. You could delegate this to the practice nurse. I like to do it myself. Dr. David Unwin, he would have 3 10-minute sessions with patients as a GP over the year, and then they were invited to have 90-minute group sessions if they wish to do that. I know a a GP who's a locum, and she simply airdrops the list from her phone to their phone, the food lists in their room. You could email patients the list, and you could refer them to websites such as Defeat Diabetes or Diet Doctor or the Freshwell app or the Defeat Diabetes app. And almost all my patients get referred to the Real Health and Wellness podcast with Lucy Burns and Mary Barson, two great GPs from Melbourne, because it's such user-friendly information and it reinforces what the clinician has said. Helpful recipe sites, just give them one, Diet Doctor, Keto Focus. And you could refer them to a mainstream dietitian. I've had very mixed results, usually poor results with doing this, but you need to, if you do this, to specify that you want a very low carbohydrate diet, and they can still be told to liberalise the carbs. They might do the dietitian course that AMS is running, and that might improve that situation, hopefully. And you need to remember, this is not a one-and-done intervention. You need to follow up your patient. There is virtually nothing we do in medicine, whether it's prescribing a blood pressure tablet to prescribing an antidepressant, where we never see the patient again or follow up with them. So you need to ask them how the diet's going, and this doesn't usually derail the consultation. It usually takes less than a minute. And if you see the bloods deviating from where they were before, you need to recall them back. And it's important that you encourage your patients. Maintenance is a very long game. Relapse happens, and everyone just needs a bit of help to get back on track. Something that I don't think enough attention is paid to is how patients and also clinicians learn. And one of the big learning theories here is the multimodal learning theory by Richard Mayer. And this states that there are two channels. There's the visual channel, which includes video as well as images. And then there's the verbal channel, which includes both text and the spoken word. And you can't overload both channels because there's a limited capacity in each. But if you can utilise both channels, you can pass quite a lot of information to the patient that's reinforced by take-home material as well. And we all know that pictures improve recall, they help understanding, and they also improve adherence to interventions. So what about working within guidelines? So all clinicians like to work on guidelines. Well, the good news is low carbs in the guidelines is just not advertised. And this is because guidelines are very much controlled by pharma and big food. But if you can know some of these guidelines, it really helps you when you're talking to colleagues. So first of all, with the Australian dietary guidelines, as Jessica Turton told us a number of years ago, these are for healthy Australians, and the patients we're seeing are not healthy. James Mukey told us a couple of years ago that the Australian National Diabetes Strategy for 2021 to 2030 recognises low carbohydrate diets as being one of 3 ways to induce remission, the other 2 being bariatric surgery and very low energy diets. And the Australian Diabetes Society released and endorsed guidelines at the end of last year about managing type 2 diabetes with therapeutic carbohydrate restriction. And the American Diabetes Association has gone so far to say that reducing carbs has the most benefit in improving glycemic control and also improves costs and outcomes for patients. And they even wrote an entire practitioner guide about very low carbohydrate diets in 2022. And finally, Diabetes Australia has on their website these best practice guidelines, which state that you can use low carbohydrate diets to induce remission and to treat diabetes. So what about those things that aren't really in the guidelines? And this is when it's really helpful to understand medical ethics. And I was taught these principles by Adam Pike, who represented Professor Timothy Noakes when he was up against the South African Medical Board for some very minute nutritional advice he'd given in social media. And these are the principles that you'll be judged upon in a court of law if you end up there for negligence. And the first principle is beneficence. Do good for your patient. And we can see that these diets do a lot of good. The second principle is non-maleficence. Don't harm your patient. And these diets have a very low risk of harm. The third principle is that of justice, that patients across the world should have access to these treatments. And we can see that a dietary treatment is going to be a lot more equitable than bariatric surgery or expensive drugs. And the fourth principle, and this is what you'll be judged most highly, is respecting patient autonomy. The patient has the right to choose with fully informed consent. And so just as I can't recommend a patient have a knee operation without telling them about the potential downsides of that operation, I can't recommend a statin without telling them the side effects of that particular drug because I want to coerce them. And equally, I need to respect their decision. I can't badger the patient. There are, of course, some pitfalls when you're practicing low-carb medicine, and the first one are the zebras. So in general practice, we talk about horses, and horses are those things that occur commonly, and we recognise them with pattern recognition. But in amongst those horses are the zebras, which are the weird and the wonderful and the dangerous. And so if something is not improving in the way you expect on a low-carb diet, you need to think again. Remember that not everything can be fixed by a low-carb diet. And what I explain to patients is it's a little bit like if you've got a metal teapot and you've left it in the rain. It might have got a bit rusty, and I can bring it in out of the rain, can really look after it, but you may not be able to reduce all those rust spots. And so patients do remain at increased cardiovascular risk, for example. I think fractured care is very dangerous. If a patient is seeing multiple practitioners and each doesn't know what the other one is doing, that leaves big gaps in the patient's care. So one of the safest things patients can do is to find a GP you like and stick to them. And if I've got a patient who is seeing me and they just want some help with interpreting their blood results that their GP doesn't know about, and they really like their GP, I definitely encourage them to stick with their GP, and I'll just help them with the blood results. Patients get derailed off diets when they see specialists, particularly cardiologists. And so it is helpful if you speak to your patients about how they could possibly talk about the diet. And this would be things like, I've cut out a lot of processed food. I'm cut out heaps of sugar. I'm losing weight. I feel terrific. My blood sugar's way better. And comfort eating and food addiction are very common and need specific treatment. And we know that the world environment's not supportive of low carb either. And for practitioners, burning out and running late are definitely risks, and that's why I do specifically also teach about that. And you can feel alone. You know, if you're the only one in your practice who's doing this, you can feel quite alone. But remember, you're not alone. There's lots of people doing this now. Join a professional Facebook group, such as the Low Carb Keto Doctors Down Under group. Join the Australasian Metabolic Health Society. We've got fantastic ground rounds every month. And the best bit is the casual chat and questions that we ask each other before and afterwards. So you really get to connect and learn from each other. So in summary, prescribing nutrition is easy. You just need some skills and a strategy. And I would suggest that you learn from clinicians. And we also need to capitalise on GP strengths. The fact that there's 30,000 of them seeing people across the country, and they're excellent at chunking, they provide very time-efficient care. They just don't know yet that insulin resistance underlies chronic disease. And remember that this is in the guidelines and it's ethical, and I hope you take comfort from that moving forward. And these are my citations for my talk today, and thanks so much for listening. I hope you have a wonderful conference.